afternoon. We'll just wait a few seconds. Good afternoon, everyone. I'm Emma Hoban, the manager of the Australian Centre for Value-Based Healthcare at the Australian Healthcare and Hospitals Association, and we'd like to welcome you to today's webinar, Advancing Value-Based Healthcare in Australia, Lessons from the NHS Wales. I'm joining you today on the land of the Ngunnawal people and pay my respects to their elders past, present and emerging. I would also like to acknowledge and pay my respects to the traditional owners of the many different lands on which everyone is joining us today and recognise their continuing connection to land, water and culture. So NHS Wales is a world leader when it comes to the adoption of a whole-of-system approach to value-based healthcare. The Welsh value-based healthcare model drives improved outcomes through an iterative, data-driven, evidence-based approach that is built on the principles of equity, sustainability and partnership. In late 2023, AWHA was lucky enough to welcome Dr. Sally Lewis, National Clinical Director for Value-Based Healthcare at the Welsh Value in Health Centre, NHS Wales, as keynote speaker for the 2023 Value-Based Healthcare Congress. Sally then joined AWHA on a 2-week roadshow for a series of discussions exploring value-based healthcare implementation in remote, rural and metropolitan locations across Australia. Today, we are joined by a panel of healthcare leaders who participated in the Value-Based Healthcare Congress and roadshow to reflect on the key lessons that we can learn from the Welsh experience of value-based healthcare and explore next steps for advancing value-based healthcare in Australia. Joining us, we have Robin Hudson, Deputy Director General of ACT Health, Quinn Parson, Chief Executive Officer, South East Melbourne PHN, Megan Callaghan, Chief Executive Officer of Marathon Health, and Kylie Woolcock, Chief Executive of AWHA. If you have any questions for our panel throughout the session, please use the Q&A function at the bottom of the screen and we will try to get to them throughout the conversation. We're going to start today, however, by hearing from Sally herself with an excerpt from the 2023 Value-Based Healthcare Congress keynote presentation.
So if you ask people, what does value in health mean? What is value-based healthcare? You'll get 100 different answers. Oh, it's cost-cutting, or oh, it's just about patient-reported outcome measures. But actually, it is a really broad, cross-cutting approach to delivering healthcare. It's a lens through which we can start to solve the problems in our healthcare systems, and it requires multiple interventions, not just in healthcare, but in collaboration with other public sector interventions like education, leisure, and so on, because we need to collaborate for better health. 80% of our health is generated from outside healthcare. Healthcare is just about the 20% when things go a bit wrong. So in Wales, we certainly favour the definition of value-based healthcare that you see on the screen, that it is the equitable, sustainable and transparent use of the available resources to achieve better outcomes and experiences for every person. And of course, that's a tall order, isn't it? When you really pick apart that sentence, there's a lot going on in there. And resources doesn't just mean financial resources, of course. It means workforce, it means digital, it means everything that we need, all of the elements to deliver healthcare for our population. And in Wales, this very much built on the concept of prudent healthcare and other professional philosophies which have grown up over the last 20 years around the world, that taps into the notion that all is not well. You know, we've had this sense, haven't we, that all is not well with healthcare for a little while. Prudent healthcare was really about looking at co-production with patients and the public, both in the consultation, looking at shared decision making, but also obviously working with communities in co-production for local services. It was also about reducing unwarranted variation in care. It was about care for those with the greatest need first. So the story that Stephen told about the person having a myocardial infarction waiting for an ambulance, that is a great need. You know, it should be prioritised, and we are losing the ability to prioritise that need because everything is just completely overloaded. Realistic medicine in Scotland, very similar to prudent healthcare. Choosing Wisely International, I'm sure you're familiar with, that really looks at a specific issue of low value care and how we might tackle that. And my personal favourite, slow medicine in Italy. If you haven't come across slow medicine in Italy before, I recommend their website. They've been going for years, and they're typically Italian. And I want to live this lifestyle. It's about slow food and slow love and slow everything else. It's fabulous. But of course you can't measure those things very well, so value in health is a really fantastic delivery mechanism for slow medicine, so I'm in. So as I was coming over on the plane, I started to read some more about what's been going on lately in value in health in Australia, and came across the Allied Health Framework from Queensland for VBHC from last year, which I think, by the way, is a fantastic document and really resonated with me, every single word. And there's a quote in here which is that value-based healthcare is a way of thinking, not a strict process that may be followed. Hallelujah. Yes, absolutely. And we need to take the principles and apply them in our own context. And so when I read that, I completely rewrote this talk, and I thought, right, okay, how do we think about that? So I'm going to run through now what I think some of the different aspects, some of the different interventions and considerations are when we're thinking about delivering value in health. And I hope you recognise some of these, and I hope that you also recognise that you're already doing this. So it's not like you're starting with a blank sheet of paper. You've all got pieces of that jigsaw puzzle to put together. So the other thing about value-based healthcare, of course, it is the great integrator. It is the great integrator across whole pathways and into social care, and it should be the great integrator between different sectors of public life so that we build healthier communities. And we all suffer from a degree of fragmentation in healthcare, and I've been hearing from colleagues here about what that means in the Australian context. Fragmentation is really, really damaging. It's really inefficient, it's not particularly safe, and it provides a horrible patient experience. So we have to tackle it and move to that helicopter view of the whole system so we can understand what it feels like to be a patient and their family moving through the healthcare system because they don't understand the arbitrary divisions in our healthcare system or why it is structured like that. They just want to be navigated through to the next step of their care and empowered to make the best decisions in their own context. So we have to move from this piecemeal approach to a much broader view, and that whole pathway approach is probably one of the, for me, the most important principles of value in health, because it means one service cannot deliver value alone. You can start, you can tackle aspects of it, but eventually you're going to have to collaborate. So population, pathways, and people. This is the way I try and chunk up value in health. So we need to think about it at a macro level, which is population health, thinking about preventative care, the social determinants of health, what that means outside of healthcare as well. So how do we build healthier communities? Processes of care, so that's really about that whole pathway and looking at whole pathway redesign, really challenging the status quo really around how we've done that historically. Over coffee I'll tell you about some research I did recently into how did we get outpatients in the UK, and let me tell you, it was nothing to do with it was the right thing to do clinically. It was much more to do about how doctors wanted to be paid, but we'll go down that road another day. I was horrified. And of course, supporting care of individuals, patients as partners in their care, because health is a contact sport. We don't just do stuff to people, we do stuff with people. And it doesn't matter whether you're trying to manage your type 2 diabetes or you're going through cancer care. Christabel, hi. We must support the care of individuals, so we'll get into some of that as well. And the picture you see at the bottom there is a representation of the whole pathway. So really making sure we're thinking with forensic detail around how a pathway is from prevention through early accurate diagnosis, optimising intervention, how we configure supportive care, because a lot of people need supportive care and follow-up for a very long time, decades sometimes, and of course end-of-life care, palliative care, where that's appropriate. So I was really delighted to see that we've got a session on palliative care, I think, haven't we, later on. So just to give you an example of what I mean by a whole pathway approach, this is from the work we're doing in Wales on heart failure, and I know colleagues have been in touch locally around some of this work. So if we're thinking about prevention in heart failure, of course we need to be thinking about prevention in terms of primary risk factors for heart disease, smoking, obesity, and so on. But it also means a critical look at the acute coronary syndrome pathway, which was why Stephen's story was so important, because actually, even if that person had survived, they would have got to hospital late. And that means a poorer outcome. It means they're probably going to have heart failure as a result of a big MI that could have been prevented. So if your acute coronary syndrome pathway is not working, and that means from point of recognition of that heart attack through to needle time and effective treatment for that heart attack, if that's not functioning, you're going to have a knock-on, low value effect in other parts of your system. Early accurate diagnosis. So we see a lot of too much medicine in diagnostics, and that means we get poorer access, certainly in the Welsh context, for people who really need diagnostics, because there are people accessing the diagnostics that don't really need them, frankly. So we need to think about that. And in the heart failure context, of course, that means NT-proBNP blood test screening before echocardiography where that is possible, because then you get the right people through to echo and you don't burn your resources in echo, whether that's because you haven't got enough workforce to do it, or enough scanners, or whatever it happens to be. Optimising intervention. So if you look at guidelines for managing heart failure, of course, it's all about titrating up the medication as soon as you've got the diagnosis, as quickly as possible, to reach a plateau of functioning. And that sounds obvious, but actually it often doesn't happen, because it requires multiple steps, multiple processes to get people up to that optimised level. It's too slow. Or sometimes, I can remember in my GP practice finding patients 5 years later who hadn't been optimised, and after a period of time, if people haven't been optimised, you start to think as a doctor, well, maybe there's a reason, and often there isn't. It's just failure, it's system failure. So we need to tackle that, and our nurse heart failure teams have been using clinical and patient-reported outcome measures within clinic to guide that optimisation, and have almost eliminated 30-day readmissions for acute heart failure. So it's not, this is not a soft thing. And they've also been able to put on, they've reconfigured the way they use their clinical time, because for patients who are very well controlled, they see them less often. They've been able to see more people and do more with what they have, not just having to have another nurse, which frankly in Wales at the moment, even if we had the money, and we don't, but if we did, we don't have the people. So it's not an option, is it? We have to think differently. So that follows on into supportive care, and of course in heart failure and many other diseases, flipping from aggressive intervention with curative intent or very strict control over into a palliative approach is very important. Otherwise you'll give people a very poor outcome towards the end of their life.
Now we're going to hear from our panelists. So welcome Kylie, Quinn, Robin and Megan. Kylie, let's start with you. As AHA CEO, you were responsible for bringing Sally out to Australia. What were you hoping to achieve by this?
Thanks, Emma. I would say we've been sort of on this journey of value-based healthcare for some time with our members, really engaging in it as the movement's growing across the world and how it's been adopted across the globe. As principles of universal health coverage have been incorporated into the models as community and population health and social and environmental and cultural outcomes are all incorporated. We saw that Sally was leading this movement in Wales, and she hadn't just been working at a conceptual level, she'd really been working with health service teams to operationalise it. So she was connecting the clinical with the data and the finance, and she was connecting the local context with that national policy infrastructure to drive things forward. The Welsh framework that she used, that she described in that short clip, it really resonated with me in terms of the challenges I was hearing health services were facing. And so I knew that her expertise would be welcome here in Australia in terms of framing discussions. But I also knew that context was important. And, well, Wales, just in geography, is very different to us. So the health system's also structured very differently to us. So I really wanted to understand whether the Welsh framework might apply not just to the Australian health system, but in helping to bring stakeholders together to drive local solutions in geographically very different contexts. So the opportunity for us to engage, and I was really excited that Quinn and Megan and Robin and also our colleagues up in Western Queensland, to give that remote perspective, were willing to sort of come on this with me and embrace Sally being here and that opportunity to have those discussions, not just because it would be about connecting that local experience in value-based healthcare, but to think about how do we systematically think about healthcare within that national policy environment so that we can enable and incentivise value and have these conversations using the same language. So it's a real privilege to have 6 months on since we first did that roadshow with Sally to have this as another step in that pathway of how we understand what we can how we create that system in terms of value-based healthcare with that transparency, as you mentioned, around outcomes, costs and context.
Thanks, Kylie. Robin, Megan and Quinn, you each hosted Sally as part of the roadshow. Can you tell us a little bit about why you were interested and then what you got from the visit and how you are moving things forward? Quinn, let's start with you.
Yeah, thanks, Emma, and good afternoon, everyone. Listen, there were 4 big drivers when we were formulating our 23 to 28 strategy path to impact. There were 4 big drivers we were getting to grips with in the environment and then working out what is our role in relation to that. Firstly, value and who's from perspective, and obviously we wanted to elevate the role of the consumer and the patient and local communities in defining value. The second was the changing needs of health needs of the population in terms of ageing population, chronic growth in chronic diseases and the like. The third was around sustainability and fragmentation in the health system, that there were real inflationary pressures in health. And if you look out 15 to 20 years, we're on an unsustainable trajectory. And from a fragmentation perspective, I think we rank 18th out of 20 in the OECD in terms of fragmentation. And fourthly, workforce, that a workforce that is reformed, fatigued, is tired, was coming out of COVID as well. And so what we're trying to find and think about, and we're very enthusiastic about in terms of value-based healthcare, was an innovative approach that could take a systemic approach to all of those problems that are very wicked problems in health, but work it through in a systemic way over time. So that's what's driven us. Where we're at now, we're still taking baby steps. I certainly, one of my great learnings from Sally was start somewhere. There are many places to start, but get started. A, and B, know that it's a mountain that will take many years to climb. And our colleagues from Dental Health Victoria who have been on this journey for 7 years have advised us the same. So that's probably where we're at, Emma.
Thanks, Quinn. Robin, can you tell us a little bit why you were interested in hosting Sally?
Well, thank you, first of all, for the opportunity to join this webinar. And perhaps what I'll do is explain a little bit about my role and where I've come from, and that will tell you why I thought it was such a brilliant opportunity to have Sally come and speak at ACT. So currently I'm the Deputy Director, as you said, of ACT Health. I focus on the policy and transformation of ACT. But I actually first started puddling around with value-based healthcare in a role in the UK in 2008 or something like that. And it showed then how important it was at making sense to clinicians, to consumers of healthcare, to academics who can evaluate and help us support with measurement, and indeed to people in roles like me who have that kind of big system-y, population-y view. And so I had recently moved to the ACT from Victoria. My background's as a clinician, as a physio. I think largely allied health spend a lot of time doing value-based healthcare at a very individual level with patients. But I had recently moved to the ACT, and the reason why I had come to the ACT, this is the perfect size population for really doing a whole of system piece of work in value-based healthcare. And so the very opportunity to have Sally come, who I had heard all about for a number of years, to speak to our system, and she did do an amazing job at speaking to our whole system, was the great ignition, I think, to us slowly starting steps within this framework in ACT. So that's why we had her come along, and thank you very much to Kylie and to you, Emma, for allowing that to happen. And what we are doing now is, I think, again, that resonated with us too, start small. We are trying to find the population segment in partnership with all of our system through various health forums, and the next one being in a few weeks' time, to really get the engagement of our whole system, because it is the integration of the system that is going to be the thing that allows the outcomes for the population to follow. So that's where we're at in ACT.
Thanks, Robin. Megan, you are the CEO of a service provider in a regional rural communities. Why were you interested in having Sally come and speak?
Yeah, thanks, Emma. I think for us, it was interesting, and just listening to people's comments, particularly Quinn's, it's like it was an opportunity to think about where we were at that particular time, and thinking about ways of working together, and how the challenges that we were facing, is there another lens that we could be looking through to try and solve some of those problems. And I guess it resonated with us with a number of key principles that Sally called out this morning around that focus on real integration. And for us, for systems to work, collaboration is absolutely key, which is cornerstone to values-based healthcare. So for us, it was probably more of a learning curve to see what we could be doing differently, and probably assess what we were doing in a better context. So I think it was a good learning curve for those in the room. But as a service provider who were already looking at collaborations of how we could work together better in the system, it was probably just opportune for us to think about that and take some learnings out of Sally's presentations.
Thanks, Megan. So throughout the roadshow, we found that the macro, meso and micro model really resonated very strongly with Australian audiences. Kylie, why do you think that is?
Thanks, Emma. And maybe, Emma, if I could get you to pull up Sally's slide so we can see it a little bit more clearly, just to talk through. So I think when you look back to the original definition of value-based healthcare, it's probably very much focused on that meso level, those processes of care. And I think that's a really useful framing for us in Australia, given those divisions of responsibility and the fragmentation between the Commonwealth and the states and territories, but also, our public and private sectors, knowing that people don't experience healthcare just in the public system. They are moving between public and private and navigating that. And we know that we need to invest more in prevention, but how do we do that in a way when incentives are not necessarily aligned to achieve that at the local level? So I think that pathway approach can bring real transparency to what happens when we invest in or focus on different parts of that pathway, and we can use data in different ways to drive improvements in those outcomes. And Sally gave that really nice example around heart failure, where if you look at that sort of that step in that pathway of optimising intervention, she talks about that's the point where they introduced patient-reported outcome measures, and it was used in the context of a nurse-led clinic And it was used to, I guess, stratify that population to say, well, these people are having a symptom burden, we'll bring those back in more regularly. Those people who are not having the symptoms, or, are managing their symptoms well, we don't need to have them come back into the clinic as regularly. And so it's, managing resources in that way, and that's where that transparency came. I think she also, reflected on prevention, that we know primary prevention is needed, but when a system's under strain, you can look along that pathway and say, well, we may not be able to invest more in primary prevention right now, but perhaps we look at secondary prevention. And she also talks about that diabetes case study where, amputation rates were through the roof. And while we know we need to go back to primary prevention, it was the secondary prevention, and they managed to really drive down amputation rates really quite quickly, as she talks about, in a 6-month period. But by looking at it across that pathway, she could, they could really, and I think she uses that term, forensically analyse. And I think that's it. It's coming together and looking at the data at each of those steps as a system, and identifying where we're going to focus our attention first or next, and work together on that. But I think it's that macro and micro that she adds to that framework in value-based healthcare, because the macro is critical for universal health coverage. And so it's really about identifying those population level initiatives. How we drive vaccination coverage is an example of that. How we think about the social determinants as being a population level responsibility, for society, for governments, not driving it down to that individual responsibility. But then also that micro approach, really recognising, as she talked about, supporting care of individuals. So we often see recognition that self-management is a critical part for the sustainability of our system, particularly around chronic care. But we often, use it as a tick box within strategies and plans, and we don't take it that step far and realise that self-management is very much a supported role, and it needs to be resourced if we want it to be done effectively and to achieve those outcomes. So when I looked at this, it's taking that framework as a whole, and it gives us that really systematic way to learn, not just within a clinical pathway, but between clinical pathways. And so learn how health services are driving that innovation locally, for them to be able to then communicate that to policymakers about where the opportunities are to do things differently.
Thanks, Kylie. Robin, as you mentioned, Sally engaged with the whole of the ACT health system. Did you find that this model of macro, meso and micro resonated for them?
Absolutely. I mean, I think it's part of that fundamental behaviour change piece. Everyone can see themselves in each part of the system, and it drives a recognition that you need all parts of the system to actually make it, to the outcome that you're after. If you ignore one, you do it at your peril, really. You don't get everyone engaged. And if you don't do that, because we're a human and relationships-driven system, no matter how sophisticated we wish to be, you need everyone to see themselves in what you're doing. And I think that particular conceptualisation supports that.
Thanks, Robin. Quinn, as the CEO of a primary care PHN, does this model resonate for you and the people you engage with?
Yeah, it does, Emma. I think to tell a little story about how we got here, and we got a number of our people to the workshop Sally ran here for us. I remember when I put the idea to 5 other CEOs, 3 of them CEOs of large health networks in southeast Melbourne, and also CEO of a community health. The question for them was, where do we start? Where do we start? And I think what this model does is it chunks it down to give everybody a starting point, no matter where they are and what role they play in the health system. And so it recognises multiple starting points, it chunks it down, and it gives everybody a role in it. So I think it's a really, really helpful model, and it allows you to think and act systemically.
Thanks, Quinn. I'd now like to start talking about how such reforms mean what they mean for the workforce. Now, Megan, I know you have a particular interest in this area. How can our workforce contribute to improving the outcomes that are improving to communities sorry, I'll start again. I haven't read that question correctly. How our workforce can contribute to improving the outcomes that are important to communities is essential to ensuring the ongoing sustainability of our healthcare system. Can value-based healthcare provide a framework to support?
Yeah, thanks. I think from my perspective, working in a rural or regional context, I think a lot of this comes down to defining value, and that's going to be different from different people's perspectives of what they value, whether that be the individual, the organisation, the funder. But ultimately, I would be looking from a values-based healthcare perspective, the individual, what they value and what they would like. Each community is slightly different. So the needs are different. And I think taking that community approach to design services that work for those communities, the workforce needs to match that. So I think we're in a situation where we need to be developing models of care that are suited to those different contexts. And so the development of the workforce has to match that. And I think we need to be, at the moment, we're in a context of, thin markets. We've got to be really thinking about how can we enable good healthcare, and how can we enable a workforce to provide that care and to accommodate changes that are occurring in terms of how that healthcare is being delivered. And I think you can only do that in partnership with communities. So for us, we've been working very much around collaborative efforts with other local providers to look at a vet trained workforce to support a clinical workforce to deliver that healthcare with communities as a starting point, to have models of care that actually deliver on outcomes and real value for what the community's expectations are.
Thanks, Megan. Robin, do you think that value-based healthcare can provide a framework for supporting our workforce to contribute to improving the outcomes that are important to communities?
Yeah, I mean, I think so. I think two things really. Everyone gets into healthcare to make things better, and so it taps into that, right? No one turns up to work, regardless of where you are in the health system, not to make the outcomes better for the people that need care. But I also think this is where concepts collide, and you end up having conversations about quintuple aim, which calls out workforce much more explicitly in the way that it thinks about it. It includes the components, the original basic components of value-based healthcare, and it also calls out equity, which I can see that NHS Wales has sort of included, and I think that's where you start getting into theoretical frameworks and how they all fit together, but broadly, yes.
Great. Quinn, we all know that change is hard, particularly when the kind of reform we're talking about, where we're changing things that we've always done, can be very challenging to people. What is needed to better support a culture of innovation in healthcare in Australia?
I think it's about bringing people around the table. I often say that in our game, 98% of what we do requires collaboration. And 2% every now and again, we might have to compete on something. So I think the key in it is collaboration. And often we do that within institutions that we work within the institutional setting. However, to address it at the systemic level means we have to work outside the boundaries of our own institutions, our own organisations. And we often have to work between, what I call between organisations in that space, which is ambiguous often. And in that space where it might not be my problem to solve, but I might be living with the consequence of it unsolved or the reverse. And so I think this idea of how you then really build out a systemic approach, a little bit like you had showed on the slide and Sally's view from end to end of from prevention and early intervention right through to the acute is really critical. And I think I often think some of the theories around social impact and the stuff coming out of Stanford University is very useful around the backbones we require that join up the system and join up different actors to solve common problems. One of the pieces of advice certainly coming out of Stanford is get really clear on what you systemically need to measure and then mobilise your resources accordingly to do that. And once you're clear on what you want to measure, once you're clear on the value you want to deliver, a lot of the institutional imperatives can dissolve to a degree. So that would be one thing. And then the second thing I'd say around mobilising that is, I think from a workforce, is how you create the authorising environments for staff and organisations to do that, so that the institutional imperative of an organisation doesn't colonise the collaborative imperative of the partnerships required to solve problems.
Thanks, Quinn. Robin, you are a leader in a whole of health service in the ACT. What do you think is needed to better support a culture of innovation?
So I wholeheartedly agree with everything that Quinn's just said. I think you need problem clarity, and that means you need the data, and you need to not already come with a ready-made solution. That's something we do all the time. So you need to be really clear about the problem you're trying to solve. You need diversity of thinking. So I would go even further. Yes, you need all parts of the health system connected. Yes, you need social care included. But actually, sometimes it's quite good to go totally wild and have someone who is from a totally different industry to start to stimulate some different thinking. And I think, and it's perfectly apt, I think as we all look at our budgets, scarce resource is actually sometimes really helpful for you to solve the problem that you need to solve. Sometimes having funds doesn't help you. And so I think if you have those three things at play, but the most important being that sort of openness and diversity of thinking, and that problem clarity will be the thing that drives it. I'd also call out the midterm review from that has been published around the NHRA addendum is probably worth having a look at, about the thinking at a kind of whole of system federal level around the opportunity of innovation at the moment.
Thanks, Robin. So Megan, the scope of practice review has recommended that rural and remote be the launch pad for funding and payment reform to better support full scope of practice and multidisciplinary teams. What will it take for this to be effective and to support innovation in rural and remote communities?
Good question. I think, you know, I really liked also what Quinn said around, for me, coming from a community services background, it's like social impact is you know, a movement and a concept that's been around for some time. And I think collaboration is absolutely key. In terms of the scope of practice, you know, change occurs at the fringes, and often decision makers, you know, are stuck between rigid guidelines. And I think if this opportunity comes too prescriptive, you won't get the innovation that you want to occur. So for me, I think that the environment is right, and I think you find that there is a lot of innovation because there are scarce resources in regional settings, that there is a lot of people already working together. And there are across the whole sector, whether that's training, employment and educational institutions, working with service providers and the health sector generally. But to be successful, I think you've got to be brave, and that means you have to actually start to lean into that area on the fringes of where the traditional models are, or we are only going to get a rehash of the same. So I hope that people come with an open mind and a brave.
Thanks, Megan. Quinn, Sally highlights that clinicians are the spenders of the healthcare system, and the importance of ensuring that health professionals are also aware of their role as stewards of the system, of the precious healthcare resources that we have. This can be quite a difficult balance for health professionals who are at the coalface. How can we better support them to balance what is best for individuals and what is best for the system?
I think for them, it's a little bit like Robin was saying earlier, clinicians turn up because they want to do a good job and they want to make a difference to people's lives. And so I think it is around bringing together the intrinsic motivations that are a part of clinicians of all persuasions, and how you mobilise that. But equally so, they're smart and capable people, and if you put a problem from a systemic perspective on the table, often they can be incredibly good in their solution focus. So that would be more broadly thinking. But at the table, I think one of the greatest things I've learned around this over the years, and one of the things that in working with clinicians that has been most influential, in being able to hold more than just the clinical perspective is the weight and the stories of consumers. We underestimate the power of them in shifting the system and the power of their voices in shifting our thinking. And certainly when I look at my own experience over the years, some of the most innovative things that have occurred and that has mobilized clinicians in their innovation has been listening and learning from consumers. So I think embedding that voice in a way, I think is absolutely crucial. So there are a couple of thoughts on that.
Thanks, Quinn. Megan, as a service provider, how do you think we can better support the health professionals to balance what is best for individuals and what is best for the system?
Sorry, can you just repeat that?
Sorry, how can we better support health professionals to balance that idea of what is best for their patient and what is best for the system or the organisation that they're providing services for?
You know, it is a balance around certainty, but also, you know, a degree of autonomy to make some clinical judgments, I guess, as well. You know, I think at the moment, from my perspective, there seems to be a real prescriptive approach, and unfortunately, it's not a one-size-fits-all sort of scenario. So I think there does need to be a degree of an ability to make those judgment calls whilst you're providing and developing those services under a good clinical governance model, and that just needs to be supported, I think.
Robin, as a clinician yourself and now a manager of a health service, how would you support the workforce to better balance these conflicting or sometimes conflicting things?
I mean, I think we've possibly all lived through periods where people have put the price tag on tubes and bits of equipment in impressors on wards. Like, that is not how to do it. I can tell you that. That is just an irritant. I've also done things where I've had to audit gloves in cupboards and then everyone just stashes them under their desks. So I can tell you none of that stuff is ever going to work. I think you just fundamentally, people want to do the right thing, and you just need to spend the time with them to understand your view, their view, everyone else's view, and about arriving at that. It goes back to that problem kind of clarity piece. What is it you're trying to solve and for whose benefit? I do think Quinn's right that we underestimate what used to be called patient pull sometime a decade ago. You know, actually treating or being in a team with your consumer is the key, right? Like, you are together to do the work, and that is the thing that will ensure that you deliver great outcomes.
Thank you. We now might turn to a couple of audience questions. So do you see the Department of Health in Canberra engaging or starting to engage through strategic planning to effectively embed a value-based healthcare approach to long-term resource allocation? Quinn, I might start with you.
Wow, that's a big question. Listen, I think there is the beginnings of it there. If you look at the 10-year primary health, it's there. If you look at what Robin was just referring to in terms of the new agreement and the midterm review, it's reflected somewhat there. If you look at what's coming out of Medicare reform last year, it's there. So I think it is there at a macro level. But is it embedded? No. And we've got years to go. Having said that, it's embedded nowhere. So whether you're a policymaker or a funder or a provider, we're a long way from embedding, and we're at the early days in this journey, and the journey will outlive us all. So our kids' generation will be picking it up as well. So I think that would be my summation of that big question then.
Kylie, this is what AHHA does, engaging in the policy conversation around value-based healthcare. What are you seeing from the federal perspective?
Yeah, I would agree with Quinn. We're seeing the language appear in plans, and we're seeing the intent, and we're seeing some of the focus on the national infrastructure that needs to be in place. And I think, as everyone has already discussed, there's lots of goodwill and intention by people who want to move this forward, but it's the the how that's the real challenge. Someone reflected to me yesterday and said, well, we've kind of done it for cancer care. You know, we really thought very strategically around cancer care pathways. And while we may not have solved all the problems, we know where they are. And I think that's one of the challenges for other care pathways that we're thinking about, is that we don't have that capacity to really forensically analyse pathways in the same way that we have achieved to some extent with the cancer care pathway. So perhaps how we look at that system approach may be an opportunity for us, in terms of cardiovascular disease pathways or things as a starting point. I think, again, we recognise, and it's long been recognised, prevention, primary care is where we need to focus our attention. But a lot of the value-based healthcare global experience has really been driven by acute care pushing out. And I think the opportunity for Australia might be about how do we actually empower primary care to start to sort of lead that work rather than having it being driven by the acute care sector, who is, obviously at the bottom of the cliff dealing with the pressures. So I think there's a lot of, opportunity, and I think there's a lot of goodwill. It's about how do we actually operationalise this and learn from each other so we can scale more quickly, spread more quickly the innovation that's happening.
Thanks, Kylie. So I have another audience question here from Nick. What role do you think the market that supports healthcare or is on the periphery of healthcare can play in realising value in the context of services that healthcare providers aren't organised to deliver but are needed? Robin, you talked before about the importance of shaking things up with ideas from different sectors. What are your thoughts?
So, as I understand it, we can't clarify the question, can we? But I think if we consider the whole system really broadly, then and we think about the intention to improve people's outcomes, you do have to consider the whole of that person's experience. So I absolutely would invite that thinking from external markets. If it's a question around the place of health insurance and private facilities, the answer is clearly yes. I mean, otherwise what happens is it's like a tube of toothpaste, right? We'll squeeze it at one end and the toothpaste will just come out and squeeze it somewhere else and it will blow out the bottom. So I think you need to be really broad in the lens that you apply across the problem that you are trying to solve, and be quite creative in the way that you think about the number of actors that are required to participate in solving that problem. I'm not sure that answers the question though. But...
No, I think it was great. Thanks, Robin. Megan, what do you think the market that supports healthcare or is it healthcare adjacent can play in realising value? In a rural community, this is particularly important as there's not always services there. So just interested in your reflection.
From my perspective, I think, and I was just reflecting on the earlier comments around this topic that we're talking about, it's, for me, looking at what is the outcome that you're trying to achieve, and then allowing you to coordinate the resources that are available to achieve that outcome. And I think often what we see is prescriptive guidelines or inputs that you need one of this and two of that and three of the other that's already been decided that you may not have access to in that community. And you have to look, that's where the innovation comes in, to do things differently. So I think, for me, who is, often responding to commissioned services to provide them in the system, it's looking at, trying to design something with community to achieve an outcome, as opposed to being driven by outputs.
Thanks, Megan. And now let's move on to asking a few questions about the role of data and evidence in value-based healthcare. So data and measurement are critical to driving and implementing value-based healthcare, yet Australia lags behind many countries, including Wales, when it comes to data sharing and interoperability. How can we improve data collection in Australia and get the data into the hands of the right people to ensure we are improving the outcomes that matter? Quinn, do you have any thoughts?
Yeah, I most definitely do on the SEMA. You're right. What we measure is what's important, and what we measure matters, so it's absolutely critical. The way we've been thinking about it is how we get up the value chain and data. If the world of data is it's one of the biggest drivers and one of the richest assets we have going. We have more information and data than we've ever had before to solve some of the most systemic and wicked problems we are facing within health and with which humanity is facing more generally. So how do we mobilise it becomes the question. Well, I think the challenge within health in relation to data, as it is similar to other problems, is how we get it into translation and how we start using the data that we have. And it doesn't have to be perfect. We spend a lot of time, and rightfully so, around how we store data, how we collect it, how we ensure it's safe, rightfully so. And the balance between the public good and the private good, and the privacy of individuals, absolutely really critical. And recently I was talking to a couple of epidemiologists, and one of them was about to retire, and I was saying, so when you look back on your career, what comes to mind? And he said, well, there is hundreds of thousands of scientific papers produced every year. However, how many of them get translated into improvements is very questionable. So I think this process of, often my little catch cry around this is we're data rich, information poor, and translation impoverished. And how we flip it to become really, really good at the translation piece, I think is the challenge for us, no matter where we are within health. So coming back to the question of how do we get the data into people's hands, I think each actor within health needs to start asking the question of what question do we want the data to start answering for us? Because that will then drive what we do with the data. We can't magically think that the data is going to start doing stuff for us. So whether you're a clinician or whether you're in a role like a PHN where you're a systems actor, or whether you're an executive like Megan running a large health service, to my mind, it's what is the question we need from the data, and then go back to the data people and ask them to start doing it, and they'll work it out. They're smart, capable people, really, really smart. And so that would be my thinking. And then it's a case of, like we've been talking about, working with practitioners and many people around the table to use that data to solve well-defined problems.
Thanks, Quinn. Megan, did you have any thoughts about how we can get the data into the hands of the right people and collect the right data?
It's a really topical point for lots of people at the moment, and it's because I think what people are trying to do is wrangle their own data and all of the compliance around privacy and cybersecurity, and also making sure that you're making good decisions. I mean, people for my organisation, we use data to help with continuous improvement and insights and reporting ourselves, but this idea of interoperability is so immature at the moment. It's a great concept, but it doesn't exist. And so until that does exist in a secure environment, the sharing of data is very difficult. So I think we're some time away from that. But what I would say is I really liked Quinn's points, and that was that if we were, if we had some consensus on what we were measuring, and that we could collect that, however we collect it, but share that at a higher level, I think we would get a better sense of some improvements. But I think it's all very fragmented at the moment.
Thanks, Megan. Robin, did you have any thoughts on these issues?
Well, I mean, I think that translation gap of 18 years is well documented, and indeed the things that go faster are usually things that go ping, bits of equipment, that kind of thing that everyone wants to pick up and play with, rather than the harder model of care changes that value-based healthcare is really demanding of us. I would say, yes, I appreciate all the need for interoperability, etc., but I don't think that's a reason not to get started. And I think often it is. We're after the most recent, the most accurate, the right data, as you asked in your question. I don't think we'll ever have the right data, and I think we have sufficient data to act now.
Thanks, Robin. I have another question from the audience, specifically for you, Robin. Have you ever been involved in a value-based healthcare procurement process?
Not in procurement, though we did explore it briefly when I was in my role in Victoria. but there is quite a lot of interest, I think, from a low value care perspective in taking that approach, because there'll be certain prosthesis, for instance, as I'm sure this person who's asked the question knows, that may be more expensive to buy the prosthesis, but leads to a better outcome over the lifetime of that prosthesis for the person. So I think there is huge opportunity to explore that here in Australia, given some of the jurisdictions have such a centralised procurement model.
Kylie, I know that AHHA is starting to think about value-based healthcare procurement from a systems perspective. I wonder if you had any thoughts that you wanted to share.
Yeah, I think echoing what Robin said, we're seeing the states are taking a real interest in this space at the moment about how they do this, to think about it not just from a cost perspective, but from an environmental perspective as well, and really looking at stage 3 emissions and how they're measuring that, but how they think about that in terms of procurement as well. So watch this space. We'll sort of be looking to share and collaborate with stakeholders across the system around value-based procurement and start to learn from each other there too.
Thanks, Kylie. So Sally highlights the fact that there is already significant expertise within our system. And I think all of you today have kind of highlighted that in your various areas of work. How can we more effectively bring the expertise together, connect the pieces of the jigsaw puzzle to support grassroots implementation of value-based healthcare? Quinn, did you have any thoughts?
Put simply, act locally while drawing globally.
Great. Nice and simple. I like it. Megan, did you have any thoughts?
I'd probably go back I like the key principles that Sally drew on, and I think collaboration sits at the core of that. That will help drive integration, I would hope. So that's certainly where our efforts are focused.
And Robin?
My favourite boss ever sent me an email once saying, just do what Nike says, which is, of course, just do it. And I do think that there is some merit in the fact that we have sufficient data, we have sufficient will. We just need to get to the clarity of the problem. And then we need to learn madly together as people execute.
Thanks, Robin. So now we're coming to our last question of the day. So if we are to advance value-based healthcare in Australia, what do you think is the critical next steps needed to support service to operationalise value-based healthcare? If you each had one wish and could only ask for one thing, what would it be? Megan, let's start with you.
Changes in the prescription style commissioning models that we currently are faced as service providers, and move towards outcome based models.
Thank you. Quinn.
Oh, I'll build on Megan's idea there. I was saying incentivise value-based healthcare and build it into health agreements and contracts and payments, and then let people get on and innovate.
Thank you. Robin.
Oh, so that is such a hard one. I would like to remove the statement primary care is federal's problem and acute hospitals is state problems, because I think that is part of the issue that we run into when we try and tackle integrated care.
Thanks, Robin. Kylie, what would be your one wish?
It's probably no surprise that I would say we need to invest in those connections. It's making sure we give time to it. We recognise its importance. It's not and it is a critical input, I guess, in order to achieve outcomes, is to build trusted relationships and to have those networks of and to support health leaders from across our system come together. So I would say that's mine.
Thanks, Kylie. That brings us to the end of our webinar today, Advancing Value-Based Healthcare in Australia, Lessons from the NHS Wales. Thank you very much to all our panellists for joining us today and for sharing your experiences as part of the roadshow and what you're doing now to advance value-based healthcare. The Australian Centre for Value-Based Healthcare hosts regular webinars on topics related to value-based healthcare. So to find out more about our events and activities, please see the AHHA website, or subscribe to receive our monthly newsletter, or join the Australian Centre for Value-Based Healthcare LinkedIn community. Once again, thank you for joining us, and we look forward to seeing you at one of our events again soon. Thank you.